Just give me just one moment.
We talk to
So we will go ahead and get started. It looks like we have a good sized crew here today, about 250 or so folks in the chat. So thank you so much for putting where you're coming from. I see folks from Norfolk and Tidewater, etc. So thank you so much. We hope that you very much enjoy this beautiful day later today, and we appreciate you joining us for our training today for mass vaccination. So next slide, please. So just as a quick reminder, we do ask that if you can, please do remain muted. If you don't want to share your screen with us today, make sure that your camera is off. You can find that icon likely at the bottom of your screen. So just make sure that your camera is off if you don't want to be projecting out. And we so appreciate you joining us for our Medical Reserve Corps COVID-19 mass vaccination overview. As I mentioned, all lines are muted. Please make sure that you're putting putting your questions in the chat box. Lean and I will be taking turns managing those questions as they come in. I will say that we talk about the vaccine towards the end of some specific questions about the vaccines towards the end of the presentation. So try and hold some of your vaccine related questions towards the end because we may very well answer those. And then we'll go ahead and get started. So we have three presenters today. First and foremost, we have Marshall Vogt, who is our COVID-19 vaccine operations section lead in our incident command structure. He is not going to be with us in person today. He's a pretty busy guy right now, as I'm sure you can imagine, but he was nice enough to record a video for us. It's been about a month or so now, so he specifically doesn't mention the Johnson & Johnson, so I just want to point out that it's a little bit aged right now because in the time of COVID, things move very, very fast. So we also have Lean Abdelaziz with us today. She's our COVID-19 MRC Medical Surge Coordinator. She's going to be talking with us specifically about mass vaccination and how our point of dispensing locations work and understanding the structure behind all of those. And then there's myself. My name's Megan Doran, and I'm our VA MRC COVID-19 coordinator. And if I saw you in our last section, thank you and welcome back again. So what should you be able to learn today? We expect for you guys to be able to understand state and local dispensing systems. You're going to be able to understand our dispensing and operating structures, and then also have an understanding of the CDC COVID-19 vaccine distribution plan and how Virginia is working within that as well. And then also some of your roles during medical countermeasure operations, as we call them. So with that, we're going to go ahead now, and I'm going to play a video from Marshall. So Lean, if you can unshare your screen, and I will start that up.
Today, and thank you for letting me talk to you a little bit about what you are going to be helping to volunteer with, and we appreciate you helping to volunteer with this massive vaccination effort that Virginia is undertaking for COVID-19. My name is Marshall Vogt. I'm an epidemiologist with the Virginia Department of Health Division of Immunization, and I'm the operations lead for COVID-19 vaccination within the COVID-19 vaccination unit here at VDH. So we've been working very diligently over the past few months to plan for the arrival of vaccine in Virginia, as well as to plan how to get vaccine out to local health departments, to hospitals and healthcare systems, and to other providers, and to get that vaccine into people's arms. And again, you as MRC volunteers are critical components of our vaccination campaign. And so again, I thank you for all of the work that you're willing to do and all of the work that you will do as we take on this mammoth task. As you can imagine, vaccinating people is something that we do every day in public health, but to vaccinate so many people in such a short period of time poses a lot of logistical challenges. We know that there are several delivery methods that we can use for COVID-19 vaccine, and so we're trying to take advantage and continue to update our plans and revise our operational strategies here in Virginia to take advantage of those. And those are hospitals and healthcare systems, pharmacies, private providers, local health departments, and then mass vaccination clinics, sites where we could have a large number of people come while still respecting social distancing, of course, and receive a vaccine. And what's complicated about this is that it's a lot different from how we've done mass vaccination, say, for flu clinics or even during the H1N1 pandemic. One, we know that COVID cases are continuing to surge across the state, and so it makes it very difficult to deliver vaccine when we already have a very stressed healthcare system, and many of the people that would be delivering vaccine are healthcare providers that are helping to take care of COVID-19 patients. In addition, the two leading vaccine candidates that we have right now require 2 doses, and they can't be interchanged, which means that not only do we have to get people to come to us once for a vaccine, we have to get them to come back within the right period of time and get the same kind of vaccine product again. And of course, it's very difficult to get a large number of people together and administer a vaccine when we know that COVID spreads very easily, especially in closed environments where people are not able to socially distance from one another. There's lots of challenges for the COVID-19 vaccination program, but we know that it really is the key to ending the pandemic, and we're committed to working together to get vaccine to Virginians and people across the United States and across the world in order to stop this pandemic. You've probably heard about a couple of the vaccines that are being used for COVID-19 vaccination. Right now in Virginia, we're using 2 vaccines, one made by Pfizer and one made by Moderna. They're very similar vaccines in terms of their mechanism of action, but they differ a little bit in terms of their storage and handling and dosing and spacing. But they all use what's called mRNA technology. mRNA stands for messenger RNA, and it's something that basically tells our bodies how to make specific proteins. Think of it as almost a stack of copy paper in your body, and your body reads that and it prints out proteins based on what the mRNA says. We do this every day in our cells and our bodies, but the vaccine takes advantage of this technology by actually telling our bodies to produce certain proteins from the COVID-19 vaccine. So when you receive the COVID-19 vaccine, your cells receive a small piece of messenger RNA that codes for the spike protein on the outside of the COVID-19 virus. Our body's cells take in that RNA, and then they produce that protein and release it out into our bodies, where our immune system mounts an immune response to it. It works on the same principles as many other vaccines. It's just that our bodies produce the antigen, that protein that stimulates the immune response, internally instead of pre-prepared antigen being injected into us. These vaccines are safe and they are effective. They've gone through the same amount of rigorous research and clinical trials that all other vaccines go through. It's just we were manufacturing them at the same time so that once those research studies ended and we knew that the vaccines were safe and effective and they were authorized for use, they were already manufactured and ready to start being released, distributed, and administered. mRNA vaccines are not going to alter your DNA. And really the only adverse side effects that have been reported are symptoms that typically occur when your immune system is working and responding to something and trying to build an immune response. That might be fever and fatigue, sometimes achiness or soreness at the injection site, but these are very minimal symptoms. They don't last very long, and they're really a sign, again, that the vaccine is working. And more importantly, it's worth just a couple days of feeling fatigued or having a sore arm as opposed to taking the risk of getting COVID and becoming seriously ill. We know that these vaccines are the best way to beat the pandemic, and we're excited to start getting them out to people. Now, as I mentioned, there's a lot of people that need to receive vaccine, and we don't have tons and tons of vaccine yet because we're still manufacturing it. So we really had to think about how to prioritize who gets vaccine when and why they need to get vaccine. The federal government, Operation Warp Speed, the Advisory Committee for Immunization Practices at the CDC, they met and determined some phases and different criteria for people to be able to receive the vaccine. The phase 1A, or the very early vaccine recipients, include healthcare workers, those that are on the front lines of the COVID-19 fight, as well as those that live in long-term care facilities like assisted living facilities and nursing homes. That's because those individuals are very vulnerable to COVID-19 and poor health outcomes, including, unfortunately, death due to COVID-19. Phase 1A individuals have been receiving vaccine for the past couple weeks. And in fact, some individuals are already getting their second doses, meaning that they're fully immunized against COVID-19. And we're excited about that, but we know that there's more work to do. The next phase, or phase 1B, will include individuals that are 65 years and older, frontline essential workers, and those aged 16 to 64 with underlying medical conditions. That's because this next group really comprises a group that can be at risk, like those that are 65 plus or with underlying health conditions for adverse health outcomes due to COVID-19, or folks like essential workers that are constantly exposed to COVID-19 because they can't work from home or really practice social distancing. We're working right now to refine our plans because the phase 1B priority group was changed a little bit from what it was originally with the addition of people with underlying health conditions and the expansion of that age from 75 plus to 65 plus. As more vaccine becomes available, we're getting it out to more providers. Remember, initial vaccine really took place, or vaccination really took place at hospitals and local health departments. But now we're starting to see other healthcare providers being able to receive vaccine, as well as pharmacies receiving vaccine. And in fact, many of those pharmacies are the ones that went in and vaccinated people in these long-term care facilities. So as we get more vaccine out, and we're looking at those different avenues for vaccine administration, like pharmacies, like these mass vaccination sites, soon we'll be able to really ramp up the number of vaccinations that are being given here in Virginia. We've set a lofty goal of about 25,000 per day by early February, and we know that we want to scale up even more to about 50,000 vaccines per day. In order to do that, we're going to need more vaccines, more sites for people to go get a vaccine, and volunteers such as yourself to help augment our public health provider force in the community. Once we're well into phase 1B, we'll start to look at the next phase, which is 1C, other essential workers. Folks that keep our country working. They keep the lights on, they keep our infrastructure working, but they're able to maybe work from home or socially distance a little bit more, so there's less of a risk for them being exposed to COVID-19. Those folks are in the next phase, what I said was that 1C phase, and we're going to be turning our attention to them as soon as we're able to. After that, we'll start to open up the vaccine to others in the population who are interested in getting it. It's not going to be mandatory here in Virginia, nor is it likely that the vaccine will be mandated anywhere in the United States by the government. We need people to trust the vaccine, trust that it works, and feel safe that they're getting the vaccine and confident in that it's going to help end this pandemic. You are ambassadors as our MRC volunteers and can help answer questions and allay concerns, and we're excited that you're here to help us do that. Thank you so much again for volunteering and for learning so much about this vaccine so quickly and how we're going to administer it to folks in order to get out into the field and start vaccinating people. We appreciate your help, and we couldn't do it without you. Thanks so much. Be safe and be healthy.
So with that, that's a word from Marshall, and Lean is pulling up our presentation once more, and then she is going to take it away from there. So we do very much appreciate Marshall. He's kind of our in-house COVID-19 vaccination guru of sorts for VDH. So we're excited that you guys are able to be able to see that recording from him. Again, it's a little bit dated. It was recorded in late January. So we will be going over more specifics that are a bit more up to date towards the end or middle of the training today. So if you have specific questions that relate to things like Johnson & Johnson, et cetera, let us know and we can certainly answer those in the chat, and we'll be sure to message that out once we get to that point. I see a question about whether that is publicly available from Marshall. We do record these sessions and then we put them on our MRC training website. So you will be able to access that recording as part of this greater training. So Lean, I will go ahead and hand it off to you. Thank you.
Thank you, Megan. Good morning, everyone. Thank you for joining us this morning and taking the time of your Saturday to learn a little bit about the point of dispensing. We call it POD. And my name is Lean Abdelaziz, and I'm the MRC Medical Search Coordinator with Virginia Department of Health's Office of Emergency Preparedness. So what are you going to learn today? These are the things that we're going to go over. So you're going to understand the public health emergencies that require POD activations. We're also going to describe the types, the purpose, and the functions of the PODs, which is the point of dispensing. Also, we're going to talk about POD operation, the function of different POD groups, roles, and responsibility for you as volunteers. So what a public health emergency? So when we say a public health emergency, we mean the ability to provide medical countermeasures in support of treatment or prophylaxis to the identified population in accordance with the public health guidelines and or recommendations. So what do we mean by that? That when we say that there's a public health emergency, that means that we need to quickly provide medical countermeasures in support to that population. With COVID-19 is a little bit different because the affected population is the whole population. Normally, a public health emergency could be a small incident at the local level that we need to quickly activate the medical countermeasure dispensing operation. So what are some of the dispensing scenarios that we normally activate our medical, I'm going to call it MCM, so our medical countermeasure dispensing operation. So we have so many different scenarios that we activate that operation. We have a public health event, we call it natural, meaning that either natural occurring diseases or novel or emerging infection diseases, for example, like the corona. We also have natural incidents like flooding, hurricanes, wildfires, any disaster that we feel there is a threat to the public and to the public health. Then we activate those mass dispensing and we give medication or vaccine to the affected population. There is also man-made incidents like bioterror attacks, small or large scale. If you guys remember back in 2001 or 2, there was anthrax letters that have been sent to the Washington, D.C. area. So that's also, we activate our medical countermeasures because sometimes it's just some bad people that they can do bad things to the public. So these are some of the public health scenarios that we as state localities we plan for, even though we know some of these are not in the population anymore, but we know that bad people can do it at their labs or whatever. So we make sure that we're ready to activate and respond to those. These are some of the required by the federal government at the state and localities to plan for and be ready to respond. So this is the response time in general. The response time changes from time to time, from incident to incident. You can see here that the incident occurs, as I said earlier, at the local level. I'm talking from left to right. So the incidents occur here at the local level. A decision will be made to dispense the countermeasures. And normally the decision, we leave it to the local health department. Local health director normally is the one responsible to let us know at the state level there is an incident occur, and he can make the decision, or she, to activate the medical countermeasures. Then all the logistic behind will happen. We start contacting the federal government, let them know, the CDC, HHS, we let them know there is an incident and we need the medical countermeasures. So we start deploying pod kits. We start, logistic stuff behind doors. We receive probably an alert. There is a pod activation. Then you start checking in, receive the briefing. We start receiving the medication with SNS, which is stand for the Strategic National Stockpile. This is a stockpile that the federal government has all the medication stored in different locations throughout the United States. And then we open the pod. This operation normally takes about 48 hours from the minute that we know there is an activation decision that has been made. We normally have to be ready within 48 hours. This is required, and we're ready. We already have our plans, we trained, we exercise, and we know that we can deliver it in 48 hours to activate the pod. So as I said earlier, the health department initial action normally comes from the health director. We call it the public health incident commander. At the COVID time, it's a little bit different because the health commissioner is now the incident commander because of the COVID-19 affected the whole United States, but also whole Virginia. So that's why it's the incident commander is at the top level from the state, which is the health commissioner. But this is a typical incident. If there's typical incident localities, then the health director at the local level will presume the public health incident command. They will initiate what we call the unified command. They request the support from the cooperating agencies, the different agencies, because we can't do this ourselves. We have to cooperate with different agencies, private or public agencies, to help us activate such a big mission. And then they determine the dispensing protocol. What we mean by that, from incident to the incident, we have different dispensing protocol that we follow. I'll go through it in the next few slides. All right, so what's a pod? I've been saying pod for the past minute or two. So pod is a point of dispensing. This is a point of dispensing that is fixed. It's already been identified in a public facility, which medical countermeasures, MCM, are given to the people to respond to a public health threat or an emergency. So these pod location is already identified by each health department or health district. We know where exactly those locations are. We trained our folks to be ready to go to those locations. We have agreements with those locations because a lot of these locations could be in a public school or in a private or in a public gym or a parking lot of locations. So we know those locations. We already contacted those people and we have agreements with them that once we say there is a public health emergency, we can use those facilities to give medical countermeasures to the public. And the primary goal of a pod, normally we triage and medicate. And then the secondary is behavioral health and record keeping. And we also public information. We want to decrease the number of the sick or people might get sick. We're not there to treat people. Normally, if people show up sick, we send them to the appropriate place or hospital. At a pod, we normally want to make sure that people who've been exposed, that they don't get sick. So that's why we quickly give them the medical countermeasures, appropriate medical countermeasures. So what's the difference between a pod and a clinic? A clinic is normally you go as an individual. It's a very individual focus. You go, they go through your medical history, your exams. So they take their time with you when you go to a clinic. It's a little bit time consuming. And if there's a transfer or there's a referral, they transfer you or refer you to a traditional, another medical professional, and it's normally set in a traditional healthcare setting, a clinic or a hospital or an urgent care, a place that is actually people know this is a healthcare setting. A pod is a little bit different. There's no exams. It's very limited records, and it's population focused. We want to make sure to give pills or vaccines to as many people as we could. So we're focusing more on a population base more than an individual. And we process the clients as quick as possible because we want to get as many people. It's an emergency. We want to give shots or give pills to as many people as we could to make sure to protect the public. And as I said earlier, it's normally a community-based, non-traditional healthcare setting We have contracts with schools, with churches, we're big universities where we can use their gymnasium, or we can use their open place to give the medication or the vaccines to the public. And as I said earlier, it's there is two types of pods. There is medical and non-medical. I'll go through it when we get to that slide. So there is two types of pods, non-medical model and medical model. And this, when I said earlier, dispensing scenarios, these are the two dispensing modalities. Medical one, which is we give non-medical, my apologies, non-medical, we give oral antibiotics. There is no medical license required. Anybody, any volunteers can give, if they train, they know how to, they can give the medication to the public, and we dispense it normally to what we call the head of household, meaning one person from that family can come in and pick up the medications for everybody in that household. We don't require everybody to show up to the pod, and it's a very minimal paperwork. We just ask for their names, if they have any allergy, and their date of birth, and then we give antibiotics. The medical pod is a little bit different. As you can tell, this is vaccine, so people need to be in to come in to get their vaccine. We need medical license required. Megan later on will go over what type of who can give the vaccine for COVID-19. And each member, as I said, from the household need to come into the pod to get their vaccines. So what's some of the roles of the state? When I mean the state, I mean the Virginia Department of Health, or localities, which is the local health department. There is so many roles and responsibility throughout the year that those agencies do to be ready and prepared to respond to an emergency. But I'm just going to give you a few examples. So for the state, at the state level, we normally VDH, receive, unpack and store and secure the medication or the vaccine, and then distribute to the local jurisdiction and other state governments. They're also responsible for the public information and communication. You can see a lot of communication and risk communication going back out to the public, educate them about COVID-19, what they need to do, what type of vaccine is coming out. These are all state function roles. Also at the local level, they're responsible to receive, secure, and dispense the necessary MCM. So this is the big difference between the state and locality. The state do not dispense medication. We leave it to jurisdiction to dispense it to their people. So we send them the medication, the local jurisdiction will dispense. So we distribute, the local dispense. And also they're responsible for the public information and communication. They send to the localities, and they let them know when is the pod is open, what type of medication is going to be there, or what type of vaccine. These are their responsibility as well. So some of the pod operating policies, we normally, for especially a non-medical pod, we don't require ID for non-medical. We ask for full name, date of birth, address, and allergy and things like that for non-medical. For medicals, there's a little more information because, as you can tell, it's vaccine, and especially for the COVID-19, we have 2 doses. So we need to get information so we can reach out to those folks to come back for their second doses, and also to see if they have any allergy. So it's a little bit more complicated when you have a vaccine than antibiotics. We don't allow media inside the pod, but we designate somebody to answer any questions, and they normally stay outside. If they have questions, if they want to take pictures, we have a public information officer, normally that person responsible to answer any media questions. We ask volunteers not to, unless you've been assigned to talk to a media person. Otherwise, you don't have to take that responsibility. Somebody at the pod normally knows what to do and knows what to say when the media show up. So this is a question for you guys, just to get you thinking. So what's the difference between a closed pod and an open pod? So when we say this is a closed pod, when we say this is an open pod, if you guys maybe throw some answers in the chat box.
So it looks like one person asked the question of whether or not closed requires appointment. Someone said indoor versus outdoor. And then we're seeing closed, you have to have an appointment. Open pod, no appointment. So for some of the answers there.
Yeah, thank you, Megan. These are mostly correct. You're right. So a closed or a private pod, they actually by appointment. And when we mean by closed, it's mean like closed, that's meaning a certain population can only get into that pod. For example, you see these days, it's for elderly and essential personnel. They can go get the vaccine. So this is a closed pod because nobody can just show up to that pod and get vaccine. So we have to make an appointment for people to come in. Another thing with the closed pod or private pod, we have some agreements with, so close a private pod, they use their own resources of that partner organization to get up the pod running and dispense medication or vaccines to their own people in their own facilities. What I mean by that, we have some agreements with different throughout the state of Virginia for those private pod to be functioning. For example, we have agreements with the different military bases throughout the Virginia. We send them the vaccine or the medication, and they can take care of their own people and the family of those of military personnel. So we send them the medication. They set up their own pod inside the facility, and they give the medication to their own people. Also, different hospitals around the state, we send them the vaccines, we send them the medication, they go ahead and take care of their own people and people who residents of that facility. If it's a long-term care facility, if it's a nursing home, this is what we mean it by a private pod. Also, there's some big companies we have some agreement with, like for example, Dominion Power. These we call them kind of essential personnel. We cannot live without power, so we make sure to send them the medication and the vaccines to their facilities so they can dispense it to their own people. So these agreements we work throughout the year, throughout the past years to set it up. So when time like this, when it comes, we are ready. When we have a closed part, a private agreement with those, these actually folks, we can feel a breathe that they've been taking care of it, and we don't have to worry about it when we open it to the public, when we open to the pod. With the COVID-19 is a little bit different because we have it on phases. So now the phases that is right now, it's a closed pod because as I said, it's for a certain population that they can come in and get the vaccines. When we're ready to open it to everybody, this is what we call it an open pod, which is open to everyone, no restriction who can go in, no appointments are needed. They're located in the pre-identified community-based facilities. The risk communication messages will be going out to the public. There is a pod location open in this high school or in this gym or in this parking lot. So this information will open when we have it and when ready to open it to the public, everybody can come in without an appointment. So as I said here, some examples of closed pod and open pods, the government examples, departments, like Department of Social Services, department, you name it, all the departments we have agreements with that we can send them their vaccine or the medication, they can take care of their own people, the jails also. And then the police as well, you know, we send it to the local police or fire or EMS, they can take care of their own people. And then hospitals, churches, some churches, big churches we have agreement with, and then some big companies as well. Open pod, the sites are normally like public schools, sport arenas, gymnasium, community centers. We have what we call it a drive-through pod. You can come in through with your car, get the shot and leave, or you get your pills and leave. And then there is the mass vaccination clinics. And they're also pharmacists. We have some agreements with some pharmacists. When we're ready to open to the public, we're going to use those pharmacists to give vaccines to the public. So here talking about pod operations, as I said earlier, the primary goal is to medicate and educate the folks. There is you greet and screen the people when they come in. We give them a form so they can review and then fill out, and then we dispense medication, which is pills, or we vaccinate if it's a vaccination pod. So I'm going to go over different pod roles. Just keep in mind those roles actually, it could be assigned to volunteers as well. So it's not just the folks or staff who work at the health department. These different positions or roles you can be assigned to if you're ready and you have the training and you feel comfortable to play that role. So pod command staff, the command staff at the top level of the pod, they coordinate. That particular person can consult overall the MCM pod side function, including the operation, liaisoning, public information, security, safety, planning, logistic administration. But basically they're in charge of the whole pod operation. We call them, sometimes could be one person, sometimes could be a full staff of command, that they're in charge of the whole operation of that pod and the safety of the people working in that pod. That particular person will be probably reporting to the emergency planner. For each health district, there is an emergency planner. So that person might report to that, or they might report directly to the health director. If the health director is the incident commander, that particular person, he or she will report to the health director. So command staff responsibilities, as I said earlier, they direct all dispensing. They coordinate with partner agencies at the pod side. For example, they have the pod at the school. They're probably talking to that school and coordinating all the logistic stuff, all the administrative stuff with that school. They communicate with HDOC. HDOC is the Health District Emergency Operation or Operation Center, which is all the people behind or work, not at the pod location itself, but probably will be at a location close to the health district or inside the health district where they can manage the operation. Or the EOC. The EOC is the Emergency Operations Center. It's at the state level in Richmond. There's normally an EOC. So the EOC, for example, has been activated in full staff since the corona hit. So since March of, or before March of last year, everybody stand by there 24 hours. There is people managing those pod and managing the operation of the pod. The health district operation, if there's a pod activated, they'll be activated as well. And they communicate, the command staff will communicate with both if they need resources or anything else. And also they act as a resources for the pod staff. So if you have a question, if you need something, you can go straight to one of the command staff and ask them. They manage small scale incidents. If anything happened during the dispensing operation, an accident, somebody fell, anything that happened, they'll be also in charge of that. And then at the end, they make sure to ensure the safety of the pod staff and clients who go through the pod. Part of the command staff, we normally have what we call it a safety officer, or sometimes they call them biosafety officer, and sometimes will be two. There'll be a safety officer who handle the safety issues, and biosafety officer who handle like a reaction to medication or reaction to a vaccine or some sort of that. So what the job description for that particular person? They monitor the clinic operation and advise the clinic point of dispensing supervisor in all matters relating to safety, including the health and safety of the clinical personnel and the clients. Well, we call them clients, the people who come in to get the medication or the vaccines. And their access and anticipate any hazards. So if they see anything that might not be something that might cause any hazards or might be not safe, they make sure to take care of that. And that particular person would be probably reporting to the pod manager or the clinical supervisor if there is a clinical supervisor. The reason why I say might be or might not be, because the pod operation is different from time to time. So for example, a pod operation could be just for 100 people. So the staff will be less. Sometimes we have pod that we want to give vaccine or medication to 1,000 people. So that pod operation will be, the command staff will be larger, and the staff who works in that pod will be more. So it might be a biosafety and a safety officer, might be 1 or 2, might be 3 people doing that role. So it depends on the size of the pod operation. So pod unit leaders, they're also part of the command staff. So they're normally in charge of a unit or a team. They oversee that operation of that particular team or that particular unit. They give briefings, they update team members, they ensure also the safety and well-being of everybody. Safety is our #1 priority for all pod operation. If we feel there is something hazard, we can stop the operation right away. The command staff can make that decision to stop the operation if they feel like there is something unsafe to the staff or to the well-being of the clients who come through. Unit leaders, normally they report to the command staff up top or an emergency planner or the health director. I'll show you guys an example of how that's set up in a structure. So responsibility of unit leaders and supervisor, as I said, they make sure the safety and welfare of their staff. They oversee the operation of each unit. They give briefings, and then they ensure staff receive adequate breaks and rest, and look for any PPP exhaustions. Sometimes people, when they wear masks for a long time or they wear a big suit, they might feel they cannot breathe or they have PPP exhaustion. Those unit leaders and supervisor, they make sure to check on everybody and make sure everybody's okay. And then they ensure the record times appropriate. So here a pod structure example. So guys, you can see where those folks that I just mentioned, they fitting. So you can see the pod manager on top. The public information officer, as I said earlier, that's somebody normally from the health department or health district will manage that, because they manage the media, they manage anybody who asks questions in terms of information, and they're gonna want to get information. You can see here the safety officer. Sometimes could be only one person who's doing the both, and sometimes could be one safety officer and one biosafety officer. They report directly to the pod manager. You can see the different unit leaders in red. And then the teams will be underneath each unit leader. We'll go next to the COVID vaccinator. This is a very straightforward job description. They prepare and administer the vaccine to clients. That particular person will probably report to a pod manager, a unit leader, or a clinical supervisor. It depends how that structure of the pod. Vaccinator support or a medical evaluator. It could be one person, it could be two people doing different, or it could be more than that. It depends on the pod size. They ensure the clients receive the proper screening and medical evaluation pre-protocols. They collect and process all patient registration and evaluation forms. They record the time in and out. You know, with the vaccine, you have to stay, I think for like 15 minutes, they evaluate you in the site. So they make sure that when you get in and when you get out, it's matched. And then that particular person or that particular people, they might report to the pod manager, a unit leader, or a clinical supervisor. So you can see where they're sitting. A clinical supervisor, there's a vaccinators, and there's a vaccinator assistant. They probably help them with the forms or making sure the forms are correct. And then they're normally a medical evaluation, a person who will be seeing the people that they already got the vaccine. They'll be probably sitting on the side, watch them or evaluate them for about 15 minutes to make sure that they're okay before they let them go. This team can expand. It might be 10 vaccinators, it might be 12, it might be 15, it might be 100 vaccinators in that. You might have sometimes 2 only vaccinator assistants that they help with the forms. A medical evaluation could be 1, 2, 3, 10. All it depends on the size of the pod. This is a question for you guys to think a little bit. Can you think of any support role or roles to the pod mission beside the one that I mentioned? If you guys want to take some guesses, so you can answer that in the chat. So any role that you can think that they can be able to support that mission beside the vaccinator, beside the command staff.
All right, so I see traffic control, crowd control, education, IT, greeter, logistics, intake. It says project management, interpreter.
Correct. These are all correct, actually. We need everybody. Everybody has a role and has something that they can give in a pod operation. You can imagine if you want to have 1,000 people coming in within 10 hours or so, we need everybody's support to help. So all of these, the one you guys mentioned, are all correct. So we start with the logistics support. That particular unit organize, direct, and coordinate operation associated with acquiring and maintaining the facility, personnel, and equipment to support the point of dispensing function. The logistic normally report to a logistic unit leader, a logistic supervisor, and sometimes a pod manager. It could be one person who's doing logistic and they directly report to the pod manager. There might not be somebody in the middle between. As I said, it depends on the size of the operation. You can see where the logistic sit in. You can see they report all the way, that logistic supervisor report all the way to the pod manager. Sometimes they call logistic unit leader, and they have people underneath them. It could be a runner, it could be an IT, it could be somebody who's taking care of the medication, somebody who's taking care of the food. So it depends on the size and the need for that particular pod. Pod admin support. There's so many admin support that you can think of, as many of you mentioned, vaccine controller, fillers, screeners, assistants, floaters, you name it. There's so many names and there's so many roles and for the admin support to that particular pod. So they normally review the screen forms. They assist the vaccinators by preparing the appropriate type of vaccines. These days with COVID-19, normally we have one vaccine in each pod, like one type of vaccine. So you know when you get into the pod that this is the type of vaccine that you're getting in that pod. But in the future, with Johnson & Johnson, with so many other things are coming, where there might be more than one vaccine in a particular pod. And that person or that particular people or that particular group will report to the pod manager directly. They might report to support services leader, or there could be a flow and traffic unit leader. It depends on the size of the pod. So greeter screener, as some of you mentioned, their responsibility to greet clients, take temperature with symptoms, directly visible ill individual to the healthcare system. As I said, we don't let anybody who's we think that they might be sick to the pod, because in the pod we don't treat, we just give medication, medical countermeasure for people not to get sick. And then we address needs such as physical, clinical, language service. If anybody needs a special assistant, that greeter screener at the front will make sure that we're taking care of that client. The form distribution review unit. By the way, all these pictures these are actual MRC volunteers within the state of Virginia helping us running those pods. So these are form distribution review unit. They record the time in, and they make sure to look at the screen, make sure the clients fill out the forms correctly, they answer any client questions, and they record the timeout when clients leaves. And also they monitor any additional assistance if that client is needed. If language assistant, interpretation, physical assistant, whatever they need, we'll make sure that unit also take care of that. The flow, as some of you mentioned, the flow and traffic control unit. If we have a pod outside, they play a very important role to direct the traffic. Even inside, you can imagine with that amount of people, we need people to control and make sure the operation is moving smoothly in a timely manner as well. So they greet the client, they direct the client to, if they have question, they'll answer the question, and they make sure the client enter from one place and leave for the other side. And they address also any special needs or any accommodation for that particular person if they need it. You can see where they're sitting. Here, the flow control supervisor, greeter, screener, flow inside, flow outside, critical supervisor, flow, the form distribution, form review. So it depends. But just here, I want to just give you an idea of these are different roles. So when you see it, you kind of tell what is probably their roles and responsibility. But they normally, the unit supervisor give briefings and give you a description of your role. They might give you a job action sheets that you can see and figure out, or you might take a training before you even get into the pod. They assign you to a role. Let's say, for example, they assign you to a form distribution role or form screening. They'll send you the proper forms to review. They will send you to the proper place so you can get the training to be informed and well to answer any questions about the forms, for example. Interpretation and special accommodation, or some of you mentioned, we assist non-English-speaking clients with understanding the information and the process of a pod. We also interpret the information between the pod staff and the clients. That particular person also identify any accommodation needed for vulnerable populations such as children, elderly, access and function needs, hearing and visual impairments. So they make sure that whoever needs an accommodation, special accommodation, we make sure that to accommodate that particular person. They probably report to support service unit leader or a pod manager. It depends where they're sitting in that structure. You can see here in this example, they sit in with the support services. There's an interpreter. Somebody mentioned earlier outreach education. If there's information that we need to pass to the public, there's probably a person there passing those information and explaining to the public. Sometimes we have counseling as well. If there is a behavior needs in that particular pod and we feel like there's a need for that, we have somebody that they can take care of that as well. So at the end of the day, we call it a pod demobilization, meaning the operation is ended, either because the period of the operation is ended. It's a 12-hour operation. It's a 10 hours, 4 hours. That period is ended. We need to demobilize. Sometimes we demobilize if there's an issue. We might run out of vaccine. So even though we said the pod is going to end by 4, we might end it a little bit early. There's a safety issue. The pod manager decided that they want to end the pod operation, then that's their decision to make. So that particular time, we make sure to secure the SNS, which is, as I said earlier, is the Strategic National Stockpile, or the MCM inventory. You will hear those two terms a lot. MCM is medical countermeasure. And then we notify the team leaders. So that pod manager will let the unit leaders know that the pod is ready to demobilize. Then the team leaders will hold a debriefing or a hot wash with their team. Their team is you guys, or you might be a unit leader. You might be the one who's actually managing that unit. So you'll give a briefing, a debriefing. We call it a hot wash. A hot wash is actually, you sit as a team, they ask you what went well, and you tell them the success areas. And then you tell them also the areas of improvement. Please speak up. If you feel like there's something particular that went well and you want to talk about it, let them know this went well, and I feel like this is a good thing that we continue doing in the pod. If you feel like you saw something in an area improvement and there's something that might be done better next time, let them know, because we always learn from these pods and we always improve our operation so we can do better the next time. The general pod staff probably will assist the pod facility staff in demobilizing or setting up for a new pod. Normally, an operation ends, a new operation might be the next day or might be in another hour or so. So we make sure the pod is ready for the next operation, for the next folks who are coming to be in charge of the pod. So tips for participating in a pod: be proactive. If you find a problem before it starts, let the pod unit leader know or let the pod manager know. Pay attention to your staff need if you're a unit leader. Be transparent, and don't be afraid to get your hands dirty. If there's something that needs to be fixed, if there's something that you feel like you can do it, go ahead and be in charge and do whatever you need to do. So pod safety and success is in your hands. We want to make sure everybody's safe. You as a volunteer, the staff, and also any clients who come through. It's your responsibility of each person to make sure that they're safe and use the information that they provided. Safety consideration, you guys 911 if you event of any medical emergency, provide CPR already if you already trained and have a CPR certification, and then inform your ICS supervisor or your safety officer if you see any injury or safety issue. And then everyone has a role. Look for the people who you work with, see if they have any sign of exhaustion, PPE exhaustion, or they're tired or they need a break. We want to take care of everybody, and we work as a team to take care of everybody's safety and well-being. We want to make sure that you're okay. If you see something, please say something. All right, so I think that's the end of my presentation. If you guys have any questions, you can post it in the chat.
Yeah, so Lean, before we move on, I do have a couple of questions that I wanted to call out. So first of all, I'll just comment on this. We'll get into a little bit more, but did want to answer a question that I believe Kelly had in the chat about how people are contacted for their second round of vaccination. So when you receive your first vaccination, we get your information, and we use at least one, sometimes two systems to make sure that we're capturing that information and following up when it's your second dose time, so that further appointments can be made. And so that's being managed at the local health district level. Someone asked Lean what SNS stands for, if you want to take that one.
Sure. The Strategic National Stockpile, it's a federal stockpile of medications and pharmaceuticals, things and hospital stuff that the federal government, what I mean by the federal government, I mean HHS, which is the Department of Health and Human Services, is under ASPR, which is the Assistant for Preparedness and Response. They have warehouses throughout the United States where they place medications and PPE and different things that the hospitals might need, beds and different stuff that we keep or they keep in a secure location throughout the United States. And when we need them at the state or local level, we contact HHS and we let them know that for ASPR, which is the Assistant for Preparedness and Response, we let them know that we need a particular thing or we need the whole SNS containers. Those SNS, they can come in. Beginning of this program back in 2002, 2001, they used to come in within 12 hours. Now they can come in within 6 to 8 hours when requested. So if we call HHS and let them know that we need something, we can receive it within 6 to 8 hours. They can come by airplane, they can come by train. It depends where is that particular warehouse is or how close to the state. The SNS, normally we use it in all different type of public health emergencies, but for COVID-19 is a little bit different because the vaccines are coming straight from the manufacturers, pharmaceutical companies, so they come straight to the state. So here, the Strategic National Stockpile were not activated during Corona viruses. It might be activated for the wildfire, for example, in California, or what happened in Texas with the snow. So to support the states in terms of their medical needs and their mission. I hope that I answered that question.
Yeah, I think you very much did. And then there was some questions about our basic supplies like EpiPens available on site. I'll quickly answer that. Very much so. If you're a vaccinator, in fact, you're required to take training to make sure that you're able to use an EpiPen. So we very much have those supplies on site. We also have PPE for vaccinators on site. If you're working in a non-medical, non-patient facing role, so to speak, you will be wearing kind of your own face mask, but you will be required to have that on at all times when on site, as the government is still requiring that just in general. And then we do require it in our localities on pod sites as well. A quick mention, I've seen a lot of questions about vaccination for volunteers. We're going to cover that in just a minute. So hang on tight, give me just a few minutes. We'll get there, I promise. That's very important, and we want to make sure we address it, but all at one time so we don't miss anybody. And then there's some questions. We've talked about MCM means medical countermeasures. And then let me just see, I think there's maybe one or two other questions. There was one question, Lean, about some of the older folks that in our population, maybe not having computer access for their vaccination. If you want to speak to that, I can say that we are contacting people via phone. So if you wanted to add anything else to that, Lean.
It's unfortunately that we don't have, at this time, we don't have a method to reach out to those population unless they live in a healthcare facilities like a nursing home or long-term care facilities or in a retirement communities. These are the only folks that we might be able to reach out, but the folks that will live at home, they have just to kind of reach out to their local health department, or they can listen to their local news or local station. They might get some information about where to go to get their vaccines.
Yep, great point. So I see that there's a question about face masks that volunteers should wear. There is not a necessarily specific, recommendation for a face mask for general support, people who are going to be working outside or maybe say as a greeter. I see a question about whether or not you can have double masks. That's certainly completely up to you, and you understand your ability and capacity to be able to double mask and wear that. It has been a possible recommendation, so you're welcome to do that. We don't necessarily turn people away for just wearing the one mask though, but we do require the one mask at bare minimum. So please make sure that you are showing up with a mask on. Otherwise, that may become a problem for you. So with that, I think that's the main questions that we had. I do want to just add to the point that you made, Lean, about our kind of elderly population. We are, of course, from our specific perspective with the Department of Health, we do very much understand and appreciate the fact that we have lots of different people in our community, and our social determinants of health impact those groups. So we have a heightened awareness of where those groups are and methods of trying to how to reach out to them. This is not necessarily the first time that we've had to try and work with different communities and different backgrounds of folks, depending on age, or health status, et cetera. to be able to reach them. So we do have ways that we can contact individuals, and we are being innovative in our approaches. But you know, this is a mass vaccination campaign, so we still are trying to utilize all of those tools to be able to have people also sign up online, et cetera. But we want to make sure that we're clear that we are looking at all varieties of being able to respond to those needs. So anything else that you had further, Verlene?
No, I'm here. If anybody has a question, I'll be online here. Thank you, guys, and we'll look forward to have you in those spots and those different positions. And don't be afraid. If you feel like you're a unit, you can be a unity leader, you can be a supervisor. Go ahead and let them know that you have capacity and the trainings that to lead a pod. So thank you all, and I'll be here.
Great, thank you so much. So Lean, if you mind moving to the next slide, please. So we're going to get into COVID vaccination now, specific. I have my vaccine vial earrings on and we're ready to go. We so appreciate you, Lean, going over the logistics of pods in general, and more specifics of COVID are on their way. So next slide, please. So as I mentioned earlier, plans are underway at both the federal and state levels. They're constantly changing, as I'm sure you all are fully aware if you've been watching the media at all in the last few months. Finalization of the specifics all depend on the approval of the vaccines by the FDA. So as you well know, and we'll get into this more specifically in just a moment, there have been 3 that have reached that approval by the FDA and are considered under emergency use authorization. And then we have a variety of pod models, as Lean kind of mentioned before. We're utilizing all sorts of pod models to be able to reach a variety of people in different localities. What works in the northern region may not work in the eastern region, and we're aware of that. We want to make sure that we're trying to utilize both the space for pods and understanding our population and making sure that we're responding in the ways that are appropriate to each of those. The Medical Reserve Corps is going to serve a very important critical role in the vaccine administration and distribution efforts. We've already been doing so, and we will continue to do so, especially in the coming months. So we do, as you've probably heard on the news recently, we do have some specific dates in mind now, especially with President Biden issuing some of his statements about wanting to make sure that everyone is able to receive the vaccine, at least the first initial dose, by the end of May. So we have, of course, taken those timelines into consideration, and frankly, we're working towards those goals already before they were announced. So next slide, please. So I did want to just show this quick little slide. This is a little bit of what Marshall was talking about before. We have different vaccines that are being worked on right now, and this is from the WHO. So some of these may not apply so much to the US, but I wanted to make sure that everybody was aware that although we have these 3 excellent, great vaccinations that are available to us in the United States, there's quite a lot that are still being worked on as well still. So there may be even more availability as we go on in the future. So we see here that there's whole virus, protein subunit, nucleic, and viral vector. And the primary ones that we've been talking about today are nucleic, which means that they use that messenger RNA, or in the case of Johnson & Johnson, double-stranded DNA to produce the immune response through those mechanisms. So next slide, please. So just a very quick kind of overview again of Pfizer, Moderna, and Johnson & Johnson. You also may hear Jansen, because Jansen is the portion of Johnson & Johnson that creates vaccinations. So if I use those interchangeably, that's why. So first of all, the Pfizer was the first one that we received an EUA for. If you guys remember back in December, we were all very excited about that here at VDH. And so the vaccine has already been, delivered the EUA. It's 2 doses, as you may already know. It has roughly 95% efficacy. That has been kind of given a boost recently with some additional studies. In some situations, it can be up to 97% effective, but at least 95% effective at preventing serious illness. Also, some potential side effects are injection site pain, fatigue, headaches, chills, etc. What you may just generally have. And then the second dose, those potential side effects are often a little bit more, I would say, severe or more pronounced, I guess would be a better word. Moderna is similar to that. It still uses that mRNA kind of sequencing to utilize in the process of the vaccination. It's also 2 doses, but it's delivered 28 days apart or 4 weeks apart. And it has about a 94.1 to 95% efficacy at preventing serious illness as well. Similar potential side effects. They actually work very similar. The main difference is the storage, which as you may know, Pfizer has been doing additional trials to see if they can alter a little bit of the ultra cold storage that was originally needed in order to maintain the vaccine. The most recent one of all of these is the Johnson & Johnson or Jansen vaccine, which is a 1-dose vaccine. It's been proven to be 72 to 85% effective at preventing severe illness, and it has similar side effects, but it uses a little bit different of a mechanism. It uses DNA for those kind of spike proteins. It does not alter DNA. I want to make sure that I'm clear about that, but it uses the DNA rather than the messenger RNA that the Pfizer and the Moderna use. It's actually, and Moderna and Johnson & Johnson are actually a little bit easier to store. And the Johnson & Johnson is, of course, the 1-dose vaccine. There are some trials that are being done right now to see if a second dose would boost the efficacy of the Johnson & Johnson. But for right now, we're sticking with the 1 dose until we hear back from the FDA on how all of those trials have panned out. So next slide, please. And then, so this is a little bit of an older chart, but it's still very important. And I like this chart and I use it a lot still because it's been given to us by the CDC. It was from the initial distribution plan that the CDC provided. And it has this nice little, what I like to affectionately call roller coaster slope to show how we're moving between the phases. So from phase 1 to phase 2 and kind of where we're ticking up in terms of our availability of the doses that are available in the community. So as you can see, we are still kind of in that red oval area of where we have limited amount of doses. We are moving closer now, closer into that phase 2, but we are still considered in the phase 1B category. I do just want to point out that the phase 1A and phase 1B descriptions here on the screen are a little bit different because this was from back in, I believe, October that I've pulled this off. May have been September. So it's a little bit older, but it still gets the point across about how we are moving between the phase 1, phase 2, and ultimately phase 3, which is when we just have continued vaccination for when we're just routinely vaccinating people for COVID-19. Phase 2 is when there's a large number of doses available. And phase 1 is where we're at right now, where we're having to be very strategic due to the limited supply to make sure that we're giving that vaccine out to people who are most at risk of having COVID-19 severe illness and who work in locations that may be of more risk. So which one are we in Virginia? So I just kind of mentioned a little bit. We are currently in phases 1A and 1B. So that means that we are moving along through that phase 1B category, but we're still trying to work to make sure that we're addressing both people that are age 65 and above, people who have underlying medical conditions, people who are living in kind of congregate facilities, and then also frontline essential workers. So as we keep going into the future phases, we hope to include more of those essential workers and expand out. And then of course, phase 2 is when that's fairly widely available and people should not have too much of an issue being able to get a COVID vaccine. And those days are getting closer for sure, but we're still not quite there yet. So we will be sure to message out when we are. So just a couple of frequently asked questions that we have. So one of the questions that was in the chat earlier was having to do with Medical Reserve Corps volunteers and whether or not they are considered to be in phase 1A. So I will say that those that are supporting what we call our mass vaccination pods are considered to be in phase 1A. So you do qualify if you are going to be working in a pod to be able to be vaccinated. So I will say that a lot of those vaccines are given out towards the end of a pod on the day that you've worked, so that we can make sure that you also don't have any kind of reaction or negative response, because just because you're an MRC doesn't necessarily mean that that we know how you're going to react to a vaccine, right? So we want to make sure that we give that to you when you have time to make sure that you don't have any kind of negative reaction. So those are typically at the end, but you can try and follow up with your MRC unit leaders before you deploy to make sure you understand when and how you would be vaccinated. They will likely, honestly, probably tell you that before you ask, but just if you don't hear from your MRC unit leader, feel free to follow up with them. There's a website here that goes a little bit more in depth about the priority groups that we've kind of just brushed over today. So feel free to go to the vdh.virginia.gov website /COVID-19 vaccine /. Next slide. And so we do have a copy of the Virginia state plan that has been submitted for review and is being actively used. It's at the same link as we shared before, so that COVID-19 vaccine link, and it's under the resources tab. So you can click on that, you'll be able to see it in around the middle of the page, and you should be able to find our full plan there. But it will be a longer, of course, version of what we've been talking about today. So the pod locations, there's often questions about whether or not they're already determined. They are already determined. And then also the timeline is often asked about for when they take place. So pod locations a lot of times have been researched and coordinated for months, sometimes years in advance, depending on what the situation is. And we likely have a good awareness of those already. We do send out whole teams of individuals to be able to research and coordinate to make sure that it's meeting all of the needs for the community that we're aiming to serve. But we don't necessarily make those public. So, and the reason that we do that is for situations like COVID-19 has presented us with, where we're having to give out a specific amount of vaccine and we can't yet invite everyone to get it. We look forward to the day that we can do that, but unfortunately right now we have to adhere to that need. So that being said, the next question we often get is how is data entered into the Virginia VIS system? So vaccination information is usually entered into a system either called VAMS, or now we're often using a system called PrepMod, and my apologies for not adding that here. But we are also using an API system known as PrepMod or VAMS to be able to make those appointments and then also enter in the medical information regarding the vaccine that's been given, so that it is able to transfer over, and so that the CDC and HHS and the Virginia Department of Health can track the number of people that have been vaccinated and then save it to their medical records so that they can access that at a later time. Also another question that we often get is how long after immunization before an immune response begins. So the immune response really starts the moment that you receive the vaccine, but it does take your body a little while to go through that process that Marshall described, kind of that copy paper process that mRNA uses, or in the case of Johnson & Johnson, that the DNA, double-stranded DNA process that uses to replicate and make sure that your body is able to fully respond to COVID-19 if it encounters it while you're out in the community. So it does take a little time. It takes about 1 to 2 weeks to be, quote unquote, to have that full, quote unquote, efficacy from the initial vaccination. And then once you receive your second shot, if we're talking about Pfizer or Moderna, it's about 2 weeks beyond that as well. So by the time you've reached week 5 or so for Pfizer from that initial shot, and then week 6 or so for Moderna from that initial shot, or 2 weeks after the Johnson & Johnson shot, you should be feeling the full benefits of those vaccinations in terms of their efficacy. So who can vaccinate? So we have updated the list of vaccinations. I had them listed here before, but we have expanded that quite a bit under a new bill that went through at the end of February called House Bill 2333. It has included both traditional and non-traditional vaccinators. So if you're needing to get more information about that, or you would like to do training for COVID-19 vaccination, you can click on this link here. It will be put on in the chat box momentarily as well, but you're welcome to go to that website and see who all can vaccinate. Again, there is quite a list of people who can vaccinate now. So, that includes, but is not limited to doctors, nurses, LPNs, who are of course nurses, but I'm thinking of RNs, LPNs, nurse practitioners. We also have, included some non-traditional vaccinators, which your health district may or may not be utilizing under their current vaccination plans. So if you're not sure, feel free to reach out to your MRC coordinator at a local level, and they can certainly answer questions for who and how someone may be included to vaccinate. You do have to have a Department of Health professionals license, however, so do know that if you're non-medical, unfortunately, you're not going to be able to vaccinate. I'm sorry, but if you do have that DHP license, you may be included in that group. So there's some additional recommended trainings that you may want to utilize after this. So they're not required, but if you want to know a little bit more about pods and get a little bit deeper dive than even we've kind of given you here today, you're welcome to take the Pod Essential Overview training course in Train, and that train number is listed here, so you're welcome to navigate there. And then for any questions that are related to this presentation today, or any general questions, you can see our contact information here. So for any COVID-19 vaccine related questions or any specific COVID-19 questions, you can email me at covid19@vamrc.org. Or you can send general questions. Let's say if you have a question about your VBHS account or any kind of issues that you're having with Train, etc., you can email those to the VA MRC at vdh.virginia.gov. That being said, we can kind of stop now and oh, that's fine, Lean, you can go to the next slide. But we can kind of look in the chat and see if we have any questions. And Lean, you may have a better understanding of those than I do. And then we will be sure to share out how to enroll for your attendance today. So if you want to go to the next.
Yeah, sure. So can you see the question here on the screen? All right. So one question is, do you require and or provide vaccination to unvaccinated volunteers? You already kind of covered that.
Yes, so definitely. I also saw a question that asked whether or not um, a person was required to be vaccinated. You are not required to be, but we do advise you, if you're not comfortable working in a pod situation without being vaccinated or fully vaccinated, feel free to wait until you have had that vaccination. We fully support that. We have a lot of volunteers who are have some health concerns that they're concerned about. So we fully support you waiting until you feel like it's appropriate for you to help out.
Right. There's a question how we're doing with phases now. What stage are we at? I think you kind of covered it, but if you want to add.
Yeah, so we are technically in phase 1A and B. So any healthcare providers, can still be considered in that phase 1A. So they, of course, get priority there, but we're also serving that phase 1B status as well.
There's a question about how about retired MDs, and I think the bill covers that, but I'll let you answer that question.
Yeah, so House Bill 2333 allows for retired vaccinations retired vaccinator groups, which MDs would be in, of course, to be able to vaccinate for up to 20 years after. So if you're having any specific questions about that, feel free to either email us or reach out to your local health district to see what all is needed from your local health district to be able to still vaccinate. We do require that if you haven't been trained in the last year or so, or if you haven't been working in the last year or so, that you do a little bit of additional, a little bit of additional work for us for your training. We just want to make sure that you're fully aware of the different airborne protocols and then bloodborne pathogen protocols as well. So it's not too much more training, but there is some additional if you've been out of the workforce for a while.
So since you're talking about that point, there's a question about for non-medical volunteers, what else they need to do to be ready to be deployed?
Yeah, so non-medical volunteers, it depends on what you're doing and what you're signing up for. So if you were to if you were being assigned a role in terms of handling vaccination for logistical support, there are additional trainings for those, and they are listed on our training website, which hopefully somebody can put into the chat. And then we also can follow up. But for for other just general support needs, say you're going to be working in flow control or you're going to be a greeter or something like that, there isn't necessarily additional requirements. You do have to have had your orientation, which if you were here this morning, you have completed now. So everyone is required to have orientation before being deployed. And then it's helpful for you to have had this optional training that you're sitting in right now, so that you kind of have a good awareness. But there's not necessarily additional training unless you're going to be in one of those kind of direct vaccine handling roles. And then
So,
we can go to the next slide or two so we can just make sure everybody.
okay, sounds good.
There
was a question about what's next. So somebody, now they took this training, they took the orientation, where they can get the communication that they can be ready.
Yeah, so make sure that everything's been uploaded into your profile, and we will be in touch with you once your profile has been approved. You'll be given notification for next steps. We've also covered a little bit of that in orientation this morning in terms of you'll be notified once you're receiving alerts, etc. And then once you receive those alerts, you can respond to those. You'll be put into a group based off of both your training and your background in terms of credentials, et cetera, for what you can do. So you will only be receiving alerts for, say, general support. If you're general support, if you're a vaccinator, you would be receiving, alerts specific to vaccination. So once you receive those alerts, just make sure that you're responding to those and that you're reaching out to us if you have questions and along the way. I do see a quick question in here about the FEMA trainings. Those are required for some health districts, but not all. Those are certainly things that you can yeah, the 100 and 700 is what we're speaking about. Those are certainly trainings that you can also attend, but they just make sure to reach out to your individual health districts, and they can tell you whether or not it is required or not for your particular health district. I can say that in Alexandria and in Fairfax, I know that those are required. So if you happen to be in those areas, they are required.
So there's a question, do you have to be in a particular, like an Arlington residence, for example, can they just only volunteer in Arlington MRC, or they join the MRC in Arlington, or they can join other MRC units?
So we do ask that you stay close to home or where you work because we want to make sure that if there's an emergency, you're close by, and we don't want you traveling 45 minutes or so to be able to deploy out when there may be people that are close by. So we do ask that you do that. There are occasionally times where we create kind of regional roles. For this particular situation with COVID, we are still kind of operating under those local health districts. So we only have you sign up for one local health district at a time. If you happen to move or anything like that, we can certainly transfer you as long as both districts are aware and notified of that. But just in general, we don't have you sign up for lots of different health districts because we want to make sure that we follow up and that we are aware of how many people in a specific area that we have to be able to call upon, so that so that you can appropriately respond quickly to those alerts.
I know we're running out of time, but there's several questions about the vaccine system that we use and how it's connected and communicated, because some people, they receive the first dose, and they use a different system when they receive the second dose. So if you don't mind speaking on that, Megan.
Yeah, you cut out a little bit, Ling. Do you mind repeating that for me?
Yeah, I'm sorry. So the question is several questions about some folks, they receive the first dose in a system, in a different vaccine system, and now when they receive the second dose, they enter the information in a different system. So they were just asking if their systems speak to each other, and if you tell them a little bit about the different system that we use.
Yes. So we migrated over from VAMS, which was just kind of the system that was being primarily used at the time, mainly over to PrepMod, because PrepMod had additional functionalities that would make things easier. I know that you may have remember a couple of weeks back or a month or two back where we were having some data challenges that were reported out in the New York Times, for example, that Virginia looked like they had not given out as many doses as other places. We were able to change that and make sure that was updated, but we migrated over to a different system and partially in response to be able to better manage that data. They do all still connect, however, to VIS. So that information is still captured in the same format. It's just a different kind of almost an electronic medical record of sorts. So, kind of like if you go to one doctor, they may be using one medical record system, but another doctor is still reporting in through the same mechanism, but it's just a different software that helps to do and connect to all of those things. So as we have a greater amount of vaccine that's going into arms and that we're making sure to coordinate, we are of course needing to make sure that data flows well. So that was part of the reason for migrating over to PrepMod, which is the primary one that we're using right now. Although we do still have the capability to use VAMS if some health districts are still trying to migrate over. So I did still want to mention that, but we do have that data available.
Last thing, a lot of people asked if they need the vaccines in order to be in a pod. You don't need. And then they ask also if they need to show up, there's a proof of they've been vaccinated. You don't need none of that. If you want to show it, that's fine. If you want to let your unit coordinator that you need to be vaccinated before you be deployed, that's fine as well. Communicate all the information with your unit leaders, but you don't need to show any proof of anything once you show up to a pod to be to work.
Right, exactly. And keep in mind that those vaccination cards, those are still public, or those not public, but private health records. And so, you know, when or if you receive your vaccination, that information is yours and you're part of your medical record. So we will not ask you for those. We may ask whether or not you would like the vaccine if it's available to you, you know, on that particular day or what have you. But so, you know, you're welcome to answer that yes or no, but we will not be asking for your medical record or any copies of that. And I saw a question about Loudon still using VAMs. I'm not aware specifically of which system that they're using, but they may still be using VAMs for some of the scheduling, but then still be using Prep Mod for other aspects as well. We're still in that migrating over phase, just because it's a big thing to change systems in the middle of several emergencies. So you know, we have that transfer has primarily been done, but some locations are still using kind of you know, both systems for different needs.
I just went back to the slide, Megan. So if anybody has more questions, we didn't get a chance to answer all questions, but if you have any question, you're welcome to send it to those 2 emails.
Right. And so we really appreciate you guys all joining us today. We totally appreciate everything. We understand that there's been so many questions. We've tried to address as many as possible. Thank you so much, Lean, for calling those out to me, because they come in pretty fast. But we do want to make sure to answer any questions that you guys have. So again, you know, feel free to reach out to us here. Make sure that you're filling out the roll call with Pod Rocks for our today's attendance form. So you can click on you can go to that link and enter in Pod Rocks. We'll stay on the line for a minute or two to make sure that you guys have all of that information that you're able to pull off. But we will go ahead and conclude today's session. And we so appreciate you joining us. And we hope that you have a wonderful day and that the weather is beautiful in your region of the state, wherever you are, and go outside and play a little.
Yeah, thank you, everyone.